All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance and human decisions decide how much damage it does. So, today I want to talk about three very different stories: a parasite that lives in your salad, Ebola racing through parts of Central Africa, and a set of Medicaid changes that could quietly, let me rephrase that will quietly reshape HIV risks in the United States. On the surface, these three stories look unrelated. One is foodborne, one is viral, hemorrhagic fever, and one is policy. Underneath, they share a much less uncomfortable truth. None of them are accidents. So let's start with the first one. Let's start at your grocery store. Cyclospora, as we know, is having a banner year and not really in a good way. Michigan is now reporting around 2,640 cases of cyclosporosis. This is a parasite that causes explosive, often prolonged diarrhea. In a typical year, we may see 40 or 50 cases in the US. Think of that jump going from a small classroom to a full high school campus worth of people all dealing with the same miserable infection. And that's not just a bad season, that's an outbreak that has been allowed to grow very large before we really got a handle on it. So, preliminary results from Michigan's investigation point to a lettuce or salad greens as a likely source. Not one brand, not one company yet, but we've now whittled it down to a category: bagged salads, bagged mixed greens, the stuff you grab because it's convenient and it's healthy. And that fits the biology. Cyclospora is a parasite that contaminates produce in the fields or water supply, then rides the supply chain into your kitchen. It has a very long incubation period, often a week or more, and requires specific testing. And if clinicians don't think about it and the labs don't look for it, it never actually gets counted or diagnosed. So, this is where policy walks into the frame. In the US foodborne surveillance system, tracking cyclospora became optional under FoodNet starting in 2025. Let me say that again: optional. This is not an abstract detail. This is a specific policy choice. Making surveillance optional is like saying, we'll have smoke detectors in some cabins on the campground and we'll just trust the others to notice when their walls start glowing. When you later discover that half the forest is on fire, you don't get to say no one could have seen this coming. You turn down the volume on that alarm. So now we have thousands of cases scattered across more than 30 states with decentralized and notably incomplete data. Michigan has numbers in the thousands. New York has several times above baseline. Ohio has hundreds, while other states are still trying to decide whether what they're seeing is normal noise or is part of the same signal. And we're telling the public to avoid bagged salads, wash produce carefully, and stick to peelable or smooth surface items until we sort out the details. These are good short term steps, but they sit on top of a deeper reality. When you weaken surveillance and under resource tracing, you buy yourself more mysterious outbreaks. Now, let's shift scenes from a salad bar to an Ebola treatment unit. And let's talk about the Bundibugyo Ebola outbreak in the Democratic Republic of the Congo. It is now being described as the fastest growing Ebola outbreak in history, nearly 2,000 cases and about 702 deaths confirmed so far. That's roughly the population of a small town wiped out in a matter of weeks. The virus has now spread into new northeastern provinces, particularly Haut-Uele and Tishapo, expanding the geographic footprint. And infections among healthcare workers are significant. African CDC reports 112 health workers infected. 35 of them are dead. And out of nearly 1,947 cases, there's about 704 deaths overall. I'm not a mathematician and I don't like doing this live on video, but I think that's we're approaching 40% mortality rate there. Those numbers are not just big, they tell you something about the conditions. If firefighters are consistently getting burned, putting out a blaze, you just don't say, wow, that must be a hot fire. You ask, why don't they have the adequate gear? Why the command system isn't working? Why they're being sent into situations that are structurally unsafe. Here, the firefighters are nurses, doctors, community health workers, burial teams. The African CDC is explicitly calling for stronger protections for these responders, better equipment, better protocols, more support, because right now, the people we rely on to break chains of transmission are themselves part of that case count. Add to that labor strikes at one of the main Ebola treatment centers, bare bones infrastructure, active rebel presence, and misinformation campaigns insisting that Ebola isn't real. That is not a neutral backdrop. That is actually an accelerant. And if you want to design conditions that help a virus outrun your response, you would combine exactly this cocktail: fragile health systems, unsafe working conditions, low trust, and delayed recognition. Clinically, Bundibugyo in this outbreak looks more like a severe gastrointestinal plus systemic illness. In other words, fever, vomiting, diarrhea in most patients, with the classic bleeding being only in a minority of cases. So, if clinicians are waiting to see dramatic hemorrhage before they suspect Ebola, they're waiting well into the movie, possibly the third act. Meanwhile, samples are being taken many days on average to reach a lab, meaning confirmation often arrives after transmission has already moved on. But but there is some progress. Oxford has launched the first human trial of a Bundibugyo specific vaccine using a ChAdOx1 platform in 50 healthy volunteers. That's encouraging. And if it pans out, it'll give us a new tool for future outbreaks. But vaccines don't fix weak health systems. They don't replace absent paychecks, repair broken roads, or dissolve armed groups. They do not by themselves undo the political decisions that leave outbreak regions chronically under resourced until a crisis becomes impossible to ignore. All right, let's move this back to the US and let's talk about HIV. My specialty, what I do when I'm here in the US, is manage people living with HIV. So here the causality is even more direct. Roughly about 46, let's just say 50% of people living with HIV in this country get their insurance through Medicaid. Medicaid is not just a payer, it's one of the main structural supports for keeping viral loads undetectable. Undetectable equals untransmittable. That equation has been one of the most successful public health interventions of the past few decades. In other words, if somebody's viral load is not detectable by lab values that we collect in the clinic, just basic blood values that blood samples that we collect, and if they are undetectable viral load, they cannot transmit HIV to their intimate partners. And that is even not using condoms, so not even barrier protection. So U equals U is very powerful public health messaging and one of the most successful public health interventions we've had in the past few decades. Okay, but starting January 1st, 2027, the foundation to this gets much shakier. A new federal rule, the so-called community engagement requirement, will require many adults on Medicaid to document at least 80 hours per month of work, volunteering, or education, and verify that twice a year. And if they don't do that, they will risk losing coverage. The rhetoric is about encouraging independence. The reality, especially for people living with HIV, is actually about introducing friction. CIDRAP, the Center for Infectious Disease Research and Policy, reports lays this out very clearly. About 11% of people living with HIV have substance use disorder, and they're more than twice as likely than the general population to also have major depression or bipolar disorder. Navigating complex paperwork, deadlines, and documentation while dealing with these comorbidities is not trivial. When you add poverty and unstable housing into the picture, you're not creating a hand up, you're actually designing a sieve. So, what happens with people who fall off Medicaid, which is going to be the inevitable consequences here? They don't stop being positive for HIV. What they do, however, is lose reliable access to antiretroviral therapy. Viral loads go from undetectable to detectable. Chronic disease becomes intermittent at best. Transmission risks through sex, injection, or perinatal routes increase. Downstream, hospitalizations for opportunistic infections rise. Costs shift from predictable outpatient care to far more expensive urgent and inpatient care. Policymakers can describe this as a budget discipline. However, in epidemiologic terms, it is reopening transmission networks that we know how to close and have closed them. Some will rely upon and land on the Ryan White funded programs in the AIDS drugs assistance programs known as ADAP, and they will fall on these as backstops. But those systems are already strained. ADAP has not seen a meaningful funding increase in years, and some states are already instituting waiting lists. You don't need a complicated model to see where this goes. If you remove medical coverage from a substantial portion of a population with transmissible infection, incidence will go up. It's not causality. It's causality rather, but it's definitely not speculation. So if we step back, the connecting thread through all three of these stories becomes very clear. Think of epidemiology the way you would as a crime scene or a fire investigation. If someone arrives in the ER with a knife in their back, you don't just chart knife present and chalk it up to random bad luck. You ask who put it there. If a campsite is on fire, firefighters don't shrug and say, well, stuff burns. They look for the ignition source, the accelerant, and whether there were basic protections in place. For Cyclospora, the knife is thousands of cases across multiple states. The who put it there includes optional surveillance, regulatory decisions about food safety, and supply chain tuned for speed and cost more than traceability. For the Bundibugyo Ebola virus, the fire is a fast-growing, multi-province outbreak with a heavy toll on healthcare workers. The accelerant includes chronic underinvestment in health systems, conflict, fragile livelihoods, and late or incomplete global engagement. And for HIV, the knife in the back is a rule that makes it harder to maintain continuous access to life-saving treatment. The person holding the knife is federal policy, passed in the name of fiscal responsibility and so-called engagement, while experts warn openly, myself included, that we will most certainly see increased HIV cases as a result. None of these are natural experiments. They are man-made experiments on how much strain our system can absorb before they fail. Outbreaks are the visible tip of that experiment. The pathogen is the mechanism, but policy is the context. When you defund surveillance, you get surprises in your salad aisle. When you neglect health workers and infrastructure, you get Ebola outbreaks that outpace prior records. And when you add administration barriers to Medicaid for people living with HIV, you get more viral rebound and more transmission. So we have to be comfortable with saying out loud, public health failures are very often public policy failures in disguise. So as you hear about cyclospora numbers climbing or the Ebola outbreak described as the fastest growing in history, or about new Medicaid rules that somehow manage to make it harder for people living with HIV to stay on treatment, try to resist the urge to see them as separate headlines. They are chapters in the same story. What happens when you treat prevention, surveillance, and access as expendable line items instead of core infrastructure? This is Resistance Radio, where natural selection selects resistance, but it's our policy choices that decide whether an infection stays a cluster or becomes a crisis. So please stay curious, stay critical, and the next time you hear about an outbreak, just don't ask, what's the pathogen? Ask, who lit the match and who turned down the alarm?